having me and for this wonderful webinar. We're very excited to be here and join you all. Just a brief introduction into InciSioN, International Student Surgical Network. With that, I'm bringing to you all the greetings of my co-chair Shiama and the entire executive board for this wonderful panel, and my congratulations to InciSioN Nigeria, InciSioN Rwanda, as well as our wonderful colleagues at FAMSA. So InciSioN, the International Student Surgical Network, is a nonprofit organization that has a membership of over 5,000 members who are students, trainees, and early career physicians all across the globe. We have members in over 80 countries. Our organization has an international team that does the global work of InciSioN and sets the global agenda for the organization, and over 50 national working groups, which are essentially the heart and soul of our organization. We were established 5 years ago, and currently our international team has 53 members, which are divided equally amongst the genders. They represent 33 countries amongst them, and there are 26 LMIC representatives and 27 HICs, and we speak about 30 languages within the team. Our work at InciSioN rests on 3 pillars of education, advocacy, and research. Some examples of the work that we do includes having internal capacity building sessions for education. We are currently also working on an e-learning course for global surgery. We have hosted a multitude of webinars throughout the pandemic and continue to host topics that are relevant to global surgery as well, depending on the dates and events that are happening, such as Global Surgery Day. Speaking of Global Surgery Day, we have a multitude of advocacy campaigns that go on throughout the year, and Global Surgery Day is by far the most important one to us because it is our day. It is a day that we take ownership of global surgery, and we raise awareness for the neglected surgical patients across the globe. And this day, which is a holiday to us, is on 25th of May, and it has been initiated by InciSioN and celebrated over the last 5 years. In terms of research, we have multiple avenues of participating in research, from internal research proposal projects that we create within our own network, as well as external collaborations, of which I can name a few, starting with the WDI project, a collaboration we had with Lifebox and Ariadne, and the most recent one, a collaboration that we had with our U.S. National Working Group, GSSA, and the LARC, Latin American Collaborative, that focused on global surgery interests and research amongst medical students and trainees. We also have internal research capacity building program and mentorship programs that builds research education and research capabilities within our membership. Finally, our research team is behind the wonderful Global Surgery Journal Club that happens every second Saturday of the month on Twitter. You can follow them at Global Surgery JC and join the discussions. InciSioN National Working Groups, as I mentioned, are the heart and soul of our organization. There are 50 of them currently, and we are hopefully going to be 62 by next month. We're very excited about that. Majority of our network is in LMICs. Our national working groups are autonomous on a local level, and it is the pleasure of the international team and the executive board to support all their efforts the best that we can, and they also participate in all our global activities based on their interest and bandwidth. Finally, I would like to invite everyone to join us for the international symposium that we host annually, IGSS, InciSioN Global Surgery Symposium, which is co-hosted with a different national working group each year. We deeply care about this conference to make it all-inclusive and inviting to all. And this year, because of the COVID pandemic, we had to postpone the conference, and it will be now held virtually in November. The dates are November 6, 7, 8, 14, and 15. You can register online. It's open now. This conference is going to be in English and Spanish, simultaneously translated, and there are Twitter and Instagram accesses for it. Thank you so much for having me and for allowing me to introduce InciSioN to you all.
Thank you very much, Katie. Really appreciate that. Now, I would love Tony Kiprono.
So much, Nelson. This is Tony Kiprono, and I am going to introduce FAMSA. So I did not prepare some slides because it is a brief introduction of about 2 minutes. So my name is Tony Kiprono, and I'm here to speak on behalf of FAMSA. So I do highly acknowledge the presence of some of the executive officials, including the President, Emma, and the General Secretary, Laura. So about FAMSA, the Federation of African Medical Students Association, FAMSA, is an independent non-political federation of medical students associations in Africa. It was founded in 1968 as a Nigerian, Ghanaian, and Ugandan initiative to foster the spirit of friendship and cooperation among African medical students. It is a project-oriented medical students body recognized by the World Health Organization and the African Union as the official international forum for African medical students. So the vision of FAMSA is to become a strong network of medical students aware of global health issues and responsive to the current questions facing the medical profession and global health. So that is briefly about FAMSA, and we are so happy to be partnering towards the success of this conference, and I hope you are also excited to this. Thank you so much, Nelson.
Thank you very much, Tony. Really appreciate that. Now, we speakers and panelists on the room. First on my list is Professor Emmanuel Makasa. Professor Makasa is a practicing orthopedic and trauma surgeon from Zambia. He leads the surgical healthcare regional work in advocacy, diplomacy, policy, service delivery, and research for the 16 SADC member states. He's the founding director of the WIT Center of Surgical Care for Primary Health and Sustainable Development. Professor Makasa served as the Republic of Zambia's global health diplomat at the United Nations in Geneva and Vienna, during which he chaired and led negotiations, resulting in the notable World Health Assembly resolutions and decisions. He continues to guide countries through their NSOP development and implementation process. He's the COSEXA 2020 Rahima Dawood Traveling Fellow, and he chairs the Surgical Society of Zambia's COVID-19 subcommittee. He sits on the advisory boards of the Pan-African Association of Surgeons, the G4 Alliance, the Lusaka Orthopedics Research and Education Trust, Lorette, and Africa Directions. Welcome, Professor Makasa.
Thank you. It's a pleasure to be here.
I would love to introduce Professor Bijendra Patel. Professor Patel is a consultant surgeon at University College London Hospital and Bath Health NHS Trust London. His clinical expertise includes laparoscopic surgery and upper GI surgery. He's a world leader in integrating technology-enhanced learning for surgical education. In October 2005, he pioneered this concept and created the world's first master's course in acquiring surgical skills by virtual reality simulation at Queen Mary University of London to globalize and fast-track surgical training. His main research interests include surgical simulation as a tool for acquisition and retention of surgical skills. He's also founder of the Society of Surgical Simulation and Journal of Surgical Simulation, which is the first academic journal dedicated to publishing. Professor Patel is passionate about technology-enhanced learning and has shared his expertise as invited speaker, international chair, and faculty at various conferences globally. You're welcome, Patel. It is an honor to have you with us.
Thank you very much.
My list is
Good
Dr.
to see
Mumba
you.
Chalwe.
Good day, everyone.
Dr. Mumba is a urological surgeon based in Southern Africa. As a pioneer in the field, she is an avid advocate for continuous development of surgical practice on the African continent through surgical education, mentorship, and research. Dr. Chalwe is a well-accomplished speaker on the local and international stage and has delivered keynote addresses at various forums, including TEDx, the World Congress of Surgeons, the Women Leaders in Global Health Conference, among others. Dr. Chalwe boasts of several awards and recognition from various organizations worldwide. She's a fellow of COSEXA, and she was awarded the gold medalist status by COSEXA. Additionally, she is an associate fellow of the American College of Surgeons, a mentor with the University of Global Health Equity, UGHE, and she's currently the Vice President for Women in Surgery, WISA. Welcome, Dr. Mumba. We're glad to have you with us. Next, I will now introduce Dr. Adewale Olusheye Adisa. Dr. Adewale is a consultant general surgeon in the Department of Surgery, Obafemi Awolowo University Teaching Hospital Complex, and a senior lecturer in surgery at the Obafemi Awolowo University, Ile-Ife, Osun State, Nigeria. His special interests are in the field of minimal access surgery, of which he has pioneered laparoscopic services in general surgery in Ile-Ife, Nigeria. He facilitated undergraduate student and postgraduate surgical trainees. He facilitated the establishment of a surgical skills laboratory that has provided basic and advanced surgical skills training for undergraduate and postgraduate surgical students across Nigeria. The 2016 recipient of a scholarship in surgical education of the American College of Surgeons. Thank you very much for joining us, Dr. Adewale Adisa. It's an honor to have you with us. Also with us is Dr. Abahuje Egide. Dr. Abahuje is, I'm sorry for the pronunciation if I'm not getting it right. Dr. Abahuje is a general surgeon and lecturer of surgery at the University of Rwanda. He completed his general surgery training at the University of Rwanda in 2016, after which he completed a research fellowship in simulation medical education at Brigham and Women's Hospital, and further a master's degree in health professions education at MGH Institute of Health Professions. Dr. Abahuje is currently pursuing a research fellowship at Northwestern University and PhD in health professions education at MGH Institute of Health Professions. Dr. Abahuje's research focuses on non-technical skills for surgeons, patient safety, and global surgery. He's interested in exploring effective strategies for training surgical care teams from low and middle income countries. Thank you for joining us, Dr. Abahuje Egide. Next, we have with us Dr. Fabio Botelho. Dr. Fabio is a Brazilian trauma and pediatric surgeon who graduated from Universidade Federal do Minas Gerais and bagged his MSc in surgical sciences from Universidade Federal do Sao Paulo, Brazil. He has been an ATLS instructor and volunteer supervisor of undergraduates and medical residents in clinical rotations and basic research. He is currently pursuing a new MSc at McGill, as well as being the incumbent June Martin Labege Global Pediatric Surgery Fellow at Montreal Children's Hospital, Canada. Thank you for joining us, Dr. Fabio. Also present with us is Dr. Oreoluwa Bajomo. She'll be joining us very soon. So she's a general surgery registrar in the Northwest region of the UK and the current treasurer for the Global Anesthesia Surgery and Obstetric Collaboration, GASOC. Growing up in Nigeria, she developed a passion for improving healthcare in LMICs and has since participated in various international global surgery meetings. She's particularly interested in the ethics of global surgery partnerships. Lastly, I wish to introduce Chidiebere Ibe. Chidiebere is a Nigerian medical illustrator and creative director at the Association of Future African Neurosurgeons, AFAN, and Young Continental Association of African Neurosurgical Societies. Chidiebere is passionate about contemporary illustrations of Black patients, and he aspires to pursue a career in pediatric neurosurgery. Thank you for joining us, Chidiebere. We're glad to have you. So moving forward, I wish to call on Dr. Abahuje Egide to give his first presentation on a panoramic snapshot of surgical simulation from the past to the present.
I'm sharing my screen. Can you see my screen?
Yes.
Can you hear me well?
Yes, we can.
So I've seen the chat box that some people are not hearing. I want to make sure that you are hearing this before I start.
Okay, yes, we can hear you now.
So before I start my presentation about the panoramic snapshot of surgical simulation from the past to the present, I'd like to thank the InciSioN Nigeria and Rwanda and the InciSioN Global for this initiative. It's very interesting to see how medical students can take initiatives to challenge the surgeon and the educators to improve the teaching technology. I remember when I was a medical student, we had struggling with the educators, with the faculty, to how they can improve the education system and so on. And I recognize, and I'd like to thank you for this initiative of improving surgical education, not only at your institution or your country, but at the continent and globally. Please keep it up, and we have your support. So the time from apprenticeship, where you had to see one, do one, and teach one, while learning surgical skills or other on your path to become a healthcare provider, has now been passed because of patient safety issues, but also there are some rare conditions that you may not be able to see during your training, yet you need to get those skills to be able to treat those diseases when you are fully practicing as healthcare providers. This when comes in simulation, and simulation is defined as a technique to replace or amplify real experience with guided experiences, and often immersive in nature, that evoke or replicate substantial aspects of the real world in a fully interactive fashion. Simulation has started years before Jesus Christ. This is the first simulation model that was built, and it was not used to teach medical students or healthcare providers, but to display or to show the life and the death. So on the left we have life, and on the right we have death, where there's no skin on the bones. Later, after simulation has been used in France, like medical students find that the simulation model that were available were not affordable. He developed the simulation model from papier-mâché to teach anatomy. In China, a full body mannequin was used to teach the different points for acupuncture, and also to communicate, to improve communication between the patient, female patient, and male doctors, because male doctors were not allowed to touch on female patient. So the female patient used to point on the mannequin where they feel pain, and the doctor can make a diagnosis and provide cure. In India, from the Sushruta scripture, who is thought to be the founder of medicine and surgery, they found that they acknowledge that repetitive practice is very important for the doctor to acquire skills to operate faster. Faster operation was mandatory in this period because there was no anesthesia, and the surgeon need to operate faster so that the patient can experience less pain. This is one of the mannequin that was used to teach the surgical anatomy, and anatomy was used also, simulation was used also in providing trauma for patient. This is Henry II, the King of France, who got a stab wound in the head, and the surgeon at that time didn't know the exact trajectory of the knife, and the queen ordered criminals to be killed and then stab their head at the same angle as the stab wound of the king, so that the doctors can understand the trajectory of the knife and come up with a cure. Unfortunately, the king died of infections. This can be considered, though this is also like unethical, can be considered like cadaver dissection that is currently used. This is the 18th century obstetric simulator that was used to teach midwife to deliver or practice complex deliveries. Now simulation has transitioned from anatomy education to surgical skills training using different models from task trainers and animal tissues in this case, and also 3D printed models to teach non-technical skills that allows interpersonal communication and teamwork in either operating room or other high stressful situation. Simulation is also using technology like virtual reality, augmented reality, and mixed reality. And they are also using standardized patient. These are the train actors that provide history to the runners, and then the runners can learn how to take history and communicate with the patient. With technology, the standardized patient can wear a suit or a jacket that has pulses and heart sounds and breath sounds that the instructor can modify depending on the disease that he wants to teach the trainees. Beyond that, simulation is used in perioperative planning and rehearsal. Currently, people can get the images from MRI and CT scan and build the models that are specific to that patient. And surgeon and surgical teams can use those models to learn, not only to treat, to acquire general skills, but also to acquire skills specific to that patient. And they can practice and rehearsal before the operation. At the time they feel confident, they can move to the operation to treat the patient, to operate on the patient. Simulation or these models are also used to communicate with the patients. Sometimes it's difficult to communicate with the patient with our medical terminology, but if you have an example of the model, you show him, this is your disease and this is how we are going to treat you, the communication improves greatly. Beyond that, simulation is used to test healthcare facilities before they can start being used. After constructing healthcare facilities, they use simulation to test if the facilities meet the requirements that will be used for. And this is the future of simulation. Speaking about this future of simulation in Africa, we need to use the interprofessional practice. We need to move beyond the operating room. We need to move beyond the healthcare industry to engage other actors like IT, finance, research, policymakers to build the solutions that will address the needs of the patient, not only now, but in the future. Thank you very much. I look forward to the discussions from this webinar.
Thank you very much, Dr. Egide. I'd now love to call Dr. Fabio to give his presentation.
Okay, good day, everybody. I hope that you can hear me. If not, please just let me know. I will also share my screen. I think that would be easier for me to pass through these slides. And I'm going to talk about improving the evidence for surgical simulation. So first of all, what is important to know is that a good simulator, we should train not only skills, but also attitudes and of course knowledge. And you want that simulation programs start here in the first star and not in the second, in the learning curve of the surgical education. And this is, for me, a reality in Brazil. Sometimes we start to use simulators just later, and after the resident had already experience with a patient. This is not the best way. The best way to start surgical simulator is here in the beginning of the learning curve. And the simulation has a lot of good points. So a low repetition without endangering the patients. It's now with the pandemic, we know that is a safer environment. We can use masks, practice social distance measurements. Also, you can focus on learning objectives, and this is very important in the learning process. You can't, if you'd like to teach just how to do a stitch, you are going to be able to do that. You don't need to have a lot of content for the student. And of course, you can reduce the use of animals. So about the evidence, I'm going to answer 4 questions. The first one, simulation is better than no training, and of course it's yes. I put here the most cited literature papers. It's impossible to do like a huge review because there are a lot of studies depending of the specialty. So I prefer to use the most cited researches, and I'm going to explain them. So this is a I study in neurology, neurosurgery training. And what you can see in this graph, in this first bar here, these are first-year residents doing lumbar puncture without any kind of training. So the overall performance was in average 50%. They did a control group, intervention group actually, and they trained these first 2-year residents before in simulation labs. And you can see here the performance was higher than 85%. It was best than this third group that was, these guys were senior residents in the last years of neurosurgery. So you can see clear here how simulation is better than no training before the contact with the patient. The second question is if simulation is better than traditional methods. So we have this systematic review, is not so young, it's from 2006, but it's the most cited systematic review about surgical simulation. And you can see here the simulation in comparison with cadaver or animal models, they don't they didn't see difference. But that's all right. We want here similar results, then we can replace the thing that we didn't want here. It was that simulator could be not so good as cadavers. So no, it's similar, so you can replace. Also, they looked for studies that compare simulation like virtual reality, serious game, with standard training, lectures, videos, demonstrator, and you can see also that simulation was better than standard training for superior studies. Just a review from Cochrane show us that virtual reality here in this case was better than the also standard training. So you can see that simulation is better than just giving lectures and demonstrating and this kind of things. And Fabio, you can ask me, Fabio, what do you think, how is the best simulator? We don't have this answer. We have a lot of simulators as it was presented, but really depends of what you want, your learning objectives. So would you like to do a general assessment, a trauma assessment that you are going to need communication skills, technical skills, perhaps computerized patient simulators, it will be the best. But if you just want to teach like technical skills, a stitch, something very basic, then the task train simple boxes with plastic devices, that would be enough. So you have to choose what is going to be the best thing for your learning objective. This is very important. And finally, this simulation improves outcomes. And here there is this special edition from Surgical Clinic of North America, 2015. They did the biggest review about that, 15 studies comparing simulation programs with outcomes. And I didn't put here because there are different of them. There was an article about success hater in venous access puncture, a decreased time to do a hernia repair. So, but the important is that in every 15 studies, they could see that using simulation labs improved outcomes. And finally, this is an article from last year showing that pediatric hospitals in the United States that have simulation-based training, they had decreased mortality of pediatric trauma in comparison with that centers that don't have any kind of simulation programs. So finally, simulation is better than on training models. When you compare with cadaver and animals, it's the similar, but you compare with just lectures, demonstration, simulation is superior. When you compare between simulators, this is not a fair thing. You have to first understand your learning objectives, and then you are going to have a good simulator for each one of your learning objectives. And of course, simulation improves patients' outcomes. So my take-home message is that simulated-based medical education should be encouraged based on the evidences we have. So thank you very much. I'm glad also to participate in the questions and comments after.
Thank you very much, Dr. Fabio. The take-home point is that surgical simulation and medical education should be taken based on the evidence.
Sure, go ahead.
Now we will be going into the panel session proper, and I would want Professor Patel to launch it by prompting our first speaker.
Now.
Okay, Prof, you can go on. We can hear you.
Okay, thank you. I'll just share my screen. So thank you to InciSioN Nigeria, InciSioN Rwanda, and FAMSA for inviting me to this webinar. I work at Royal London Hospital and St. Bartholomew's Hospital, which are the oldest hospital in UK. And my clinical practice is laparoscopic surgery, and academic interest is simulation and education. We are in the fourth industrial revolution, which means we have all the technology at our disposal: artificial intelligence, virtual reality, augmented reality, etc. We know what we want to teach and how we want to teach and how we want to learn as well. And we want to be more and more inclusive and immersive in our surgical education and skills acquisition. Taking example of laparoscopic surgery, this requires special skills, and learning curve for laparoscopic surgery is quite steep because of the nature of surgery. So why should surgical skills be acquired by simulation? We've already heard a little bit about that and the importance of simulation in surgical training and education. And we've seen, and there's plenty of evidence in the literature that shows that simulation training translates into better performance and a shorter learning curve in operating theater. With that aim in mind, back in 2005 at Queen Mary University, I launched the first laparoscopic surgery and surgical skills master's course, which was purely based on acquiring surgical skills by simulation. And we now have 3 programs, one of which is a global program that you can, anywhere in the world, including in Africa, anybody can take, and everybody's eligible as long as you are a qualified doctor. We have created an immersive hybrid learning environment with an online platform, classroom, and teaching module which utilize AR and VR with hands-on simulation training. All this is supplied as part of your training course. Course is to sort of accelerate surgical training and improve surgical skills, and with huge emphasis on research method and understanding and carrying out research as part of the course. The course is competency-based training curriculum, and as of now, there are only 2 competency-based training curriculum available for laparoscopic surgical training, which is a laparoscopy passport, it's called. This is a UK-based training curriculum offered by the Association of Surgeons of Great Britain and Ireland, and Fundamentals of Laparoscopic Surgery, which is available in the US. These are competency-based training curriculum. They both have similar practical training exercises, and these are integrated into the master's course in Queen Mary. We provide all the hardware that is necessary. You need to have laptop and internet connection. You can train remotely, and just as we are in this webinar connected, and I'm sharing my screen on Zoom, you can connect your box trainer and get live feedback, training, and assessment of your performance. We've also recorded operation in virtual reality, so you can actually come in the virtual environment of my operating theater and learn. And we have created modules for learning using VR headset, which is quite cheap and easy to buy. And most of us have access to a mobile phone and internet, so you can be virtually present in the operating theater. And this is an online learning platform. Now, method of teaching is participatory teaching method. You may be familiar with the learning pyramid. Lectures, reading, knowledge retention is 10 to 15%. If you want to learn, you want to engage in participatory teaching method that involves discussion, practicing by doing, and teaching others. Practicing by doing is where simulation training comes, and your knowledge retention will be very high the more you practice. Digital surgery. You may be aware of touch surgery. If not, I would encourage each and every one of you in the audience who is a trainee to download this app. It's called Touch Surgery. It's free to use and it's available globally. It helps you build cognitive confidence before you enter the operating theater. And there's evidence in the literature to show that the skills transfer into better performance from learning on digital surgery. This helps you build your cognitive confidence. I was asked to speak a bit about research and simulation. So what is the role of research in simulation? Research helps us to improve our practice. That's sort of the answer in a nutshell. If you look at the most important quotes in businesses, if you cannot measure it, you cannot improve it. Management is doing things right. Leadership is doing the things right. Now, if you believe in this, then you are running your business blind. If you don't measure and you don't challenge, then that's a disadvantage. You want to measure your performance just as you want to measure your morbidity and mortality in the hospital in a patient, and you want to challenge your bosses, your consultants, your leaders to make sure that you have evidence-based practice, both in training as well as in patient care. So does simulation training transfer to improve clinical performance? Yes. In UK, this was back in 2006, Department of Health looked at Good Doctor, Safer Patient, a document which was published by the government looking at 4 high-risk industries: surgeons, airline pilots, nuclear power unit engineers, offshore oil rig installation managers, and they saw that everybody has simulation-based competency training and assessment except surgeons and doctors, and hence they recommended this should be integrated into the training. Similarly, back in 2011, the government looked at technology-enhanced learning and concluded that the integrating technology-enhanced learning will improve patient outcome, safety, and experience. Now, with technology, these are very fancy state-of-the-art virtual reality simulators that I happen to have access to, where you can measure the performance, and I'll share some of the data from my unit. You can measure, when you train on simulators, you can measure your performance. Here's an example of path length of 10 trainees before and after training. Now, path length of a surgical instrument is an important indicator for measuring performance. Similarly, time to finish an operation is also an important indicator when you're training by simulation. And here we have shown that with training on simulation, you can improve and speed up the learning process. There's a Cochrane database, a systematic review published in 2013 on virtual reality training in laparoscopic surgery. Again, the conclusion was that it lowers the operating time and better operative performance. So there's plenty of evidence in the literature to show that. What is the role of 3D in minimally invasive surgery? Now, you might think that we don't have access to 3D laparoscope. However, you'll be surprised that you have actually, all of you have access to 3D, and I'll show you why. This is some of the research that we carried out in our department, published in World Journal of Surgery 2014, to show that training in 3D improves your performance and reduces error. Similarly, impact of 3D training in 2D laparoscopy. Again, if you train in 3D for a little while and then go and perform in 2D environment, your performance is better, your error rate is lower. Looking at different types of vision system, we have consistently shown that you can improve your performance and reduce error. So this is a low-cost simulation training in 3D that can be used globally, which is called open box training. Again, there are articles in the literature to show that open box laparoscopic surgical training transfers into a better performance and skills acquisition in operating theater. You can all create a homemade laparoscopy box trainer, keep it open and learn using laparoscopic instruments so that you have fulcrum effect. And when you translate this experience into a box trainer or a virtual reality trainer or animal model or even human model, you will find that your training and your performance is better, your learning curve is shorter. So you all have access to 3D training. Now, methods or metrics to access technical and non-technical performance and similar in the OR. There are several methods that are available in the literature. You just have to search and use it for self-directed learning as well as for formal assessment and feedback. There are generic assessment scales, OSATs, procedure-specific assessment scales, observational clinical human reliability analysis, video feedback, and patient outcome clinical data when you come to translating into patient care. Here's an example of OSAT, which is a subjective but a global operative assessment of laparoscopy skills, which has 5-item global rating scale. This is an example where you assess, you can use this for self-appraisal or as a feedback from a senior, where you're looking at respect to tissue, time and motion, instrument handling, etc. Similarly, we've created an objective assessment model for laparoscopic suturing, where the steps of laparoscopic suturing are broken down and you're scored yes and no. And by getting a structured objective feedback, you can improve your performance and you can see where strengths and weaknesses lie. Performance criteria for competency. We know the domains of learning described by Bloom in 1956 is a cognitive skill, which is knowledge. This can be tested. It is regularly tested in your examination, university examination, and Royal College examination, etc. However, it's a psychomotor skill or the manual of the physical skill, which is not tested, which as surgeons, it's critical. Clinical competence and certification. Does documented simulator competency equal clinical competence? And what is the role of simulation for certification and residents and practicing surgeon? Now, this is all very well established already in the literature. The documented simulator competence can equal. However, it's a bit like you can have a driving license, but you're still going to have accidents if you're not careful. So it's not foolproof. And again, reflecting back to the fundamentals of laparoscopic surgeon, lab pass, and other competency-based training and recertification, which are already available, ATLS, basic life surgical support, etc. All this goes to show that competency-based training and certification is here to stay. How can we use simulation to teach and assess judgment and decision-making in routine and crisis situation, and what type of feedback methods are most effective? Simulate crisis. You can simulate almost everything, technical and non-technical skill. A simple way to simulate and learn and get feedback is just video recording your own performance. You don't need any high-tech instruments. Here's some example of video and self-assessment in the literature published this month on improvement in surgical technique from video feedback. This is an article which we published again this month on effect of verbal feedback, video feedback, and self-assessment on laparoscopic intracorporeal suturing. A structured video feedback facilitates reflection and self-directed learning, which improves the ability to develop proficiency in surgical skills. Combining both self-assessment and video feedback may be beneficial over verbal feedback alone due to the advantages of video review. These techniques should therefore be considered for implementation to surgical education and curriculum. You can always measure and video record on a mobile phone and go back and review your performance. If you look at high impact organization, they've realized that they cannot achieve large scale social changes through service delivery alone. Knowledge sharing and advocacy initiative are important for promoting surgical simulation. In conclusion, I'd like to say, as a trainee, learn to do simple research early in your career. Engage early on simulation-based training for technical and non-technical skills, and conduct research on cost-effective simulation for training and assessment, and take every opportunity to teach. Again, I'd like to remind you of this learning pyramid. The best way to learn is to teach. So take every opportunity. I welcome you to join Society of Surgical Simulation, which is free to join, and please visit the website. Once again, I'd like to thank InciSioN Nigeria, Rwanda, and the Federation of African Medical Student Association for inviting me to this webinar, and a big thanks to the steering team as well. Thank you.
Yes, thank you, Professor Patel. Now, I would love to invite Dr. Adewale Adisa to now we are moving ahead. We've seen the evidences, we've seen the proofs. What challenge exactly has Africa faced despite the evidence in terms of surgical simulation? What challenges has Africa faced generally?
Okay, thank you. If I may share my screen now. So I'd like to thank InciSioN Nigeria, InciSioN Rwanda, and FAMSA This has been a very exciting webinar. And I also like to thank Dr. Fabio and Professor Patel, because first thing I'm supposed to say, you have actually done too much justice to that. There's overwhelming evidence in support of adoption of surgical simulation, and a common thing in surgical education that simulation is incorporated. I personally feel that there are peculiar advantages of adopting simulation in sub-Saharan Africa, especially because the number of training centers are fewer. There is a higher trainee-tutor ratio, and if one trainer, a tutor, has so many residents or medical students to teach, then simulation is one of the best ways to go about it. There's also low volume centers performing few surgeries but training large number of residents. And so I personally feel that Africa, sub-Saharan Africa in particular, has a lot to benefit by adopting surgical simulation. However, the adoption of simulation is still low generally in Africa. And what are the reasons why? There seems to be a culture of the traditional method of doing things. A lot of our trainers and very senior surgical educators learned in the traditional method in years past, and it appears as if this has been passed down as a culture, and a lot of pride goes with having a horde of medical students flocking around you on the ward round, some of them virtually saying nothing, and it's becoming quite difficult to change that culture. I also think from culture, it's very easy to assume that the trainers know these benefits that have been beautifully presented by Dr. Fabio and Professor Patel, but a lot of trainers are possibly not exposed to simulation themselves. And if you have not trained in using simulation, you probably won't adopt it to train your own trainees. So we need to look in that direction of exposing trainers who probably have done their training without any exposure to simulation, engaging them, teaching them, and bringing them on board to be able to adopt simulation for training surgical residents. A lot of curriculum in a number of medical schools I've been to in Africa are the same curriculum that have been used for decades. And a lot of this is based on books and knowledge, like the pyramid Professor Patel just showed beautifully now. You keep seeing lectures and lectures and lectures for medical students. And imagine giving lectures on suturing. So these are areas that I think have been quite challenging to adopting simulation for surgical education in Africa. The curriculum needs to be changed to adopt proficiency-based learning. Finally, I personally think the issue of cost we cannot overlook, because a number of simulators that are also used for training, quite a number of them are quite expensive, and a number of systems are not able to afford the high cost of initial setup. But like Professor Patel just mentioned right now, the way to go is to adopt low cost, and I'll be showing you examples from our own skills laboratory in the teaching hospital where I work and the university where I work. For instance, we train our undergraduate medical students in suturing skills, and we have a number of these models that we purchased, but because of the very expensive cost, we are not able to deploy this for the large number of medical students we have. So the way we went was to create cheaper models like this, and we have recently published on the training of our undergraduate students using low-cost suturing skills models like the one displayed here. In terms of cost, we, in our skills lab, we only have one of these closed box. We can't even afford the 3D and all kinds that are commonly available in Western countries now. But because of the large number of surgical residents that want to get their hands on training in laparoscopic skills, we run training skills with our own locally adapted and fabricated closed boxes like this. And we have quite a number of them that each resident just comes to the skills laboratory with their own laptops and just connects themselves to any of these boxes, and they're able to train on their own. So this is how we go around the issue of cost. Of course, to train stapled low rectal resection, you need a pelvic simulator. We can't get one imported because of the cost and because of restriction in importing such. So we were able to fabricate locally a pelvic simulator. So I think the way to go for adoption of this is to adopt low-cost, locally fabricated simulators for training residents. With this, we have been able to train a number of very enthusiastic surgical residents. I think it's doable, and I think in spite of the many challenges, we can still encourage people to adopt surgical simulation in sub-Saharan Africa. I'd like to thank you once again for inviting me.
Dr. Adisa, if I can just make a comment quickly. I'm really impressed with your simulation setup and the improvised box trainer. I suggest you keep the box open for training for 1 hour before you close the box and let them train. So open the box and let them watch directly. That is 3D laparoscopic training.
Excellent. I got that from your presentation, and I just
that is very effective.
Down.
Especially for laparoscopic suturing, you will realize if they see it directly in 3D, the brain, the motor connections in your brain and your arm movement will sort of speed up quickly. So just keep the box open for needle handling and suturing especially.
Thank you very much. That's helpful.
Thank you for the presentation and all the details you gave us about innovations and using for our local methods to understand surgical simulation and how it's very helpful to students all over. So I'd like to prompt Dr. Abahuje Egide, and they tell us there are any factor windows of opportunity and possible models to replicate, referring to partnership models in high income countries, the partnership between high income countries and lower middle income countries models. For example, Rwanda and Canada, Rwanda, like the Rwandan First Center for Simulation and Skills Training, simulation-based learning globally, and also tell us the lessons learned from high-income countries, the research partnerships that are available, and if there are any in Africa, it would be a specific advantage. Thank you very much.
Thank you. I think as most of the speakers highlighted, in a way, like it is being done in the Western part of the world. But there are some solutions like what Dr. Adewale Adisa mentioned, like adopting low-cost solution. And this is feasible. So, and a mixture of both, like low-cost solution or local solution to what is done in the Western part is also feasible to improve surgical simulation. And I think cooperation is necessary to advance
medical simulation in Africa. So, and I think that every member of the partnership should have the commitment and the willing the partnership to build the simulation center in Rwanda. The partnership with the Canadian University from Halifax, and they came. The university provided the infrastructure to host the simulation center, and the partners brought the equipment, and the university provided the staff to run the simulation center and support the faculty who teach the simulation center. And starting a simulation center is not enough to run the simulation center. It's the simulation center. But if you are not able to run the simulation center, if you are not able to support the faculty, if we can use those 2 weeks of short-term mission to learn from those experts, that can be very helpful. And the best way to achieve this is not to shadow them while they're operating or to observe them while they're operating. We can use low-cost simulation materials to learn those skills. And then by the time they are there, we can spend a day or 2 days, depending on the complexity of the skills we are running, run to perform the skills, then operate with them. And by the time they leave, we have some level of skills, and maybe after 3 or 4 missions, we can be able to take care of our own patients. Another solution is to cooperate with other industries. If you look into like companies that sell medical like simulation equipment, they don't have representatives in Africa because they don't see Africa as a customer. So there's no need to invest in shipping equipment in Africa where there's no one who will buy it. So as African universities, African doctors, we need to partner amongst ourselves and see how can we advance simulation, how can we interest those companies to come and sell their products and decrease the cost. You know, as the access to HIV drugs, initially they were very expensive, but with negotiations, the US and other high-level people negotiated with the companies. They said, if you decrease the cost of your product, of the treatment, you will get a lot of buyers. A lot of people are going to buy the drugs, and you will benefit from the number of patients getting your drugs. How can we use the same approach? Ask them, we have the will and the capacity to use your simulation, your product, if you decrease the cost, and they can benefit from the increased market instead of keeping the product at higher cost that no one is going to afford. Another solution can be to partner with IT people. We have a lot of smart people, even at our university in information technology, like the schools. They are making a lot of fun things, but that are applied in other industries like gamification and so on. How can we partner with them? We can pitch problems, and they can find the solution to us. This interprofessional education is needed because there's no way we are going to address the problems of patients if we continue to work alone. We have to move outside the medical school, go partner with other schools like business school, science schools, computer science schools, and so on. Tell them the problems. For sure, they find the solution to us. But if we stay in our comfort zone, we are not going to find the solution. I'm be happy to take any question or comment from the participants. Thank you.
Thank you very much.
Thank you, Dr. Abahuje.
You are welcome.
Dr. Abahuje, if I can just make a comment. I've already sort of mentioned in the chat about simulation companies not wanting to sell products because it's not necessarily profitable. But if you look at intermediate to advanced skills training, that but for knowledge acquisition, there are plenty of digital platform, digital surgical platform, and virtual reality, augmented reality, which are very cheap and widely available with technology.
That's great. Thank you.
Thank you.
Yes, please go ahead.
I just wanted to ask a question. Thank you for the talk.
If people are going to give you feedback on what can be improved and so on, and if they like it, they will support it, and your idea will be sustainable. I mean, your solution will be sustainable. But first of all, is interprofessional collaboration.
And if I can add to that, Angel, research. The key to your success is starting with research and validate your idea scientifically. So try your model or whatever idea you have a prototype, try it out with undergraduate, with postgraduate, with junior residents, senior residents, consultants, collect some data, publish that, and then you will have a big portfolio to go to a company to say, here, see, look at this, this works. I've shown it works, and this is my idea, so I want to commercialize it. So that's how you do it, is research.
Thank you.
Thank you very much. I would like to remind all the participants in this virtual conference to remember to put questions in the chat box because of the interest of time. So I'm sorry, that's how it has to be. We'll go to a Q&A session after all the speakers have spoken. So I would like to thank Dr. Abahuje Egide for the overview and how he told us how important medical missions, international collaborations, and multidisciplinary collaboration is important in developing the sustainability, the partnership, and its importance in creating new opportunities for surgical simulations and their sustainability from all the learning that's adopted from different countries across the world. So I would like to prompt Dr. Oreoluwa Bajomo. I'm sorry if we're pronouncing names wrongly, but I hope it's fine. I really appreciate what you've done for us and being here. So I'd like you to tell us from a surgical resident's perspective. I'd like you to share your experience in surgical training using surgical simulation. Also, what ways do you think simulation-based training could be more training-focused? You can refer to your friends in ATLS training modules in different countries, your ICU or emergency room experience, all the basic surgical skills, techniques that you've learned, and the flexibility that goes with it while you're training. So it's very important to learn your perspective and know how surgical residents are being exposed to surgical simulation. Thank you.
Okay, hello. Can you see my screen?
Yes, we can.
Great, fantastic. So my name is Oreoluwa Bajomo. I am a surgical registrar currently working in transplant surgery in Liverpool in the UK. So I'm going to tell you, thanks Arsen for introducing me. I'm going to tell you a bit about my background and about ways in which surgical simulation, the factors to consider in surgical simulation from a trainee's perspective, because there are lots of areas to do with surgical simulation in trainees, and I'll briefly talk on simulation to begin with, but I'm sure some of these aspects have been covered in a bit more detail. So just very quickly, why have I got a picture of a pilot's cockpit? Because about 10 years ago, I was sat in my dad's cockpit. My dad's a pilot, and I wondered how on earth does he remember which button to press when there's an emergency? There's buttons on top of you, at the bottom, on your left, on your right. it's nearly impossible. And then through my medical training, I've come to learn that actually the aviation industry has had significant improvement in their safety to do with introducing simulation training. And actually from about 40 years ago, which is somewhere about there, you can see the downward trend in airliner accidents per million flights. So in healthcare, in surgery specifically, we've seen the benefits of this. We've introduced it in terms of WHO checklists, and now specifically to do with simulation training. And in surgical simulation, I've quoted this paper because I think it just encompasses what we're discussing today, which is it is a great idea and its time has come. But this paper was written in 2012, I believe, which was more than 10 years ago. And actually, we're still not where we need to be in terms of surgical simulation for trainees across the world. It's a similar situation in high-income countries, low-income countries, where trainees recognize that there is more that can be done. They recognize the benefits and they're keen to engage further. So I'll talk briefly about aspects of surgical simulation which are relevant to trainees. So there's the clinical aspect and the non-clinical aspect. A lot of people, when they think about surgical simulation, think just about suturing, about gaining surgical skills, laparoscopic skills, but it goes a lot further than that. Surgical skills, first of all, you can talk about the clinical aspects, such as surgical skills, basic surgical skills, where you go into a wet lab, you have bovine specimens, and you do lots of learning. But then beyond that, being a surgeon is so much more than being in theatre. You have patients who need management in critical care, you have patients on the ward who are quite unwell. You need to understand the physiology of dealing with patients, not just operating on them, and then trauma. So that's another aspect of surgical simulation, which is relevant for trainees. And then finally, as Prof Patel was alluding to, another aspect is the human factors aspect of surgical simulation. And fairly recently, the Royal College of Surgeons in England introduced a course. It's called the NOTS course. It's the Non-Operative Technical Surgical Skills. It's very complex to explain, but actually essentially what it means is being a surgeon is a lot more than just your patients. The things that come into play are how you interact with your colleagues, your communication skills, your leadership skills. There are lots of factors that actually we take for granted and you think people just either have or don't have, when in reality, if you become aware of these factors, you recognize what your strong points are, what your weaknesses are, it's easier to work on these things. And just on the side there, I've just briefly highlighted some of the modes of delivery of these various types of simulation. So like the wet lab, like I mentioned, the mannequins, which you might use for the ATLS and CRISP courses, virtual reality, like we've discussed earlier, and human role play, which is more relevant for things like human factors. And I'll go into it in a bit more detail, but just to address one of the points that was raised about funding and those sorts of things. Actually, again, a lot of people don't pay attention to the human factors aspect of surgical training. And if that was simulated in trainees across the world, that would cost nothing, because it would involve researching the available resources online and sitting down and working through it and going over it repeatedly. Moving on, my personal background, in medical school, I had about 5 months of surgical experience, during which I did a bit of suturing, a few sessions, I'd say. In my foundation year, which is the internship year, I did a surgical skills course, the basic surgical skills. Again, that was like the wet labs, like I've mentioned, a bit of physical, just suturing. And then as I've moved on, I've done more and more advanced courses. So I've done a few laparoscopic skills courses, anastomosis courses, the NOTS course like I was describing, and then as I'm now in my higher specialty training, I'll be moving on to doing cadaveric courses where it'll be more detailed. And this will be, this will be the theme across the world, where when you start off in medical school, move on in your training, you will gradually move on from simpler simulation onto more difficult simulation or more complex simulation. So what's relevant when you're talking about surgical simulation for trainees. And again, like I keep saying, this is worldwide. You have to consider the cost of the simulation resources, the cost of traveling to where the resources are. Not every trainee is fortunate enough to have, for instance, like a lap skills box in their hospital. So you have to consider, even if you do have these facilities, are they accessible to trainees? Are they in reasonable positions for them to get it? What hours are these these facilities open from? Do they close at 5 o'clock when everybody finishes work? Those are the kind of things you need to consider. And then in terms of cultural and ethical considerations, you need to consider, like I mentioned, one of the courses that I did had bovine specimens. In some countries, that's not ideal, that's not acceptable. So you need to factor, specifically where you are, the trainees who are going to be participating, and you have to tailor it. Again, when you come to things like human factors, you have to consider the cultural implications of being in certain countries. Again, then the trainees' motivation, what are they interested in? A urologically interested trainee is not going to be as keen to participate in a lap Coley skills course. So you have to tailor the courses to the trainees, their interest. And then another thing that's important is making sure there's a way to give feedback, because that's the most important, one of the most important aspects of simulation. There has to be a feedback cycle to ensure that trainees are aware of what their weaknesses are and that they're improving. With regards to training grades, like I mentioned, the more junior trainees are more likely to do the simpler courses, and then the more senior trainees, more complex courses. So that again is worth considering. What stage are the trainees at? What can you provide? Again, it's very difficult, especially in times of COVID, to make sure you have the right number of trainers available. But one way to counter that is to look for courses whereby trainees can actually mentor each other and support each other. And then something that a lot of papers have alluded to with surgical simulation is that sometimes participants can be quite intimidated, because you're in a public environment, your colleagues are next to you, they're watching you suture, they're watching you do this procedure, and it can be quite intimidating if you don't feel confident that you know what you're doing or you're very good at it. So that's one factor to consider when setting up simulation for trainees, trying to ensure that it's done in a way where trainees don't feel intimidated, they don't feel like they're put on the spot, they have an opportunity to learn and to grow. And then, like I mentioned, the time at which the training is set up. It shouldn't be in times where people are at work or meant to be going home and they can't access the facilities. So I've kind of spoken a bit about some of the things that can be done to improve training, surgical simulation training from a surgical trainee perspective. Engagement from the trainees. I mean, of course, we can't put it all down to the training bodies or the hospitals. Some of this motivation has to come from the trainees. So from the trainees' point of view, what can you do? You have to be engaged. You have to go out there and look for what's available. You have to explore the free resources that are available, first of all, and then set up groups amongst yourselves and decide that this is an area that you want to improve, and make the most of those, taking initiative. And then repetition. So because you've done a course once does not mean that that's where it ends. Like the basic surgical skills course, they have a CD which people watch over and over again, because it's important to go over these things repeatedly to ensure that you've you really assimilated what you've learned. Mentorship skills amongst themselves, advocacy, research. If a group of trainees came up to their training body and said, actually, there's a lot of benefit to be had from simulation, this is what the research shows, then it's more difficult to say no to that. Then from the training bodies, there's a lot of responsibility in terms of integrating surgical simulation into the curriculum with assessment, feedback, trying to make sure that you have twin partnerships. Something that's really important on this point is that a twin partnership does not have to be between a high income and a low income country. Actually, there is a lot of frugal innovation going on amongst low-income countries, and that is a treasure mine that's not adequately explored. For instance, one of my senior consultants has set up a course, which is like the CRISP course. The CRISP course is it's training for surgeons in terms of managing critically ill patients. He sets this course up in India for essentially a fraction of the cost of what it is in the UK. So for instance, accessing those kind of facilities and saying, instead of trying to start from scratch, what's available out there, how can we reach out so we can replicate this in our own environment? So that's very important. Like we mentioned, sponsorship from industry, but if you get it, great. If you don't, you still have to make the best of what you have available, and ensuring that the resources that are available are adequately spread out amongst the various training grades. And especially in a time of COVID, we have to be flexible in a mode of delivery. I mean, we've got a conference going on, a webinar, so those are the kind of things that will make it easier for trainees to participate. And those are just some of my references. Any questions at all?
Thank you very much. That was such an elaborated and detailed presentation. Thank you very much. I'm sure if there are any questions, it will be addressed at the end. So the next question will be for Professor Emmanuel Makasa. And this is such an interesting question. So more recently, the global surgical community is becoming conscious of a possible neo-colonialist phase of global surgery. How does or should the perfect partnership model for surgical simulation training in Africa look like? You can maybe tell us about the alignment with local interests, that is the simulation model specific to common surgical conditions, or the global health funding models, and so on. Professor Makasa, you can go ahead.
Thank you so much for the opportunity, and thank you to all the presenters for the great presentations that you've made so far. I also thank the hosts for bringing up such an innovative topic, especially in the now, while we are all under lockdown and are trying to use most of our technology to see if we can continue to move forward. And so this is a great step forward. On the issue of neo-colonial approaches to engagements between human beings, unfortunately, as human beings, we carry with us the good and the bad everywhere we go. And neo-colonial mentalities like racism and other inequitable approaches are not always very good, but they are part of us as human beings. And so we see ourselves carry them through. And in global surgery, though of course it's not been very overt, but there's been trends and approaches that have been very offensive, especially to the recipients. And obviously, the ideal partnership model for surgical simulation training is something that we don't want to have this kind of approach or this kind of tent. We would like it to be free of any neo-colonial approaches or any other despicable human approaches that are not welcome and are always very retrogressive. That said, that's the ideal, but we can go, like you said, into a few specifics. And it's also important to understand the trends, because it's very difficult to change everything overnight. So obviously it's something that would take time, and it has also been there for some reasons, not good reasons, but some reasons. And one case in point, like you can say, is the issues of funding for global surgery or global health. Global health has really mostly been advanced by the Western or high-income countries, because the primary driver has always been equity in service delivery or whatever it is that we want to do, and justice. And so when you look at funding for global health work, global surgery being one of them, and the simulation and modeling being a subset of global surgery. Whether the funds are coming from a government or they are coming from any institution that offers a grant, most of the institutions or funding agencies have always wanted to work traditionally with entities that they know, that they are in their area of, so they would most likely give entities that work in the low-income countries. They know their accounting mechanisms, they can account very easily, they are a little bit more efficient in accounting for the money. But unfortunately, that has also presented problems on the receiving end, in that even when the intention is good, we have had challenges in how much or what really gets to the ground. We have noted over time that most of the finances are actually used by the receiving high income entity to build capacity to deliver, but very little then really gets to the ground. And then for the high income entity that is actually receiving the funds to get the money, normally they have to develop a protocol or a grant proposal with which they go and seek for other reasons approved with very little input and prioritization from the low income country recipients or partners on the ground. In the end, it comes to be like low income country partners are just called in to rubber stamp. So you are just called in to come and say, we want you on the grant because it shows that you've been consulted or you're a representative. But even then, it's not so much that it's an institution in the low income country that is consulted or involved. The collaboration is between me as Emmanuel Makasa and InciSioN USA. It can be like that. Institutional partnership is much more stronger, is much more better, so that even the prioritization becomes much more easier, because it's not okay to develop a protocol and get money in our name when we have not contributed at all to the priority setting for that particular funding. Yes, we can agree that we don't want to finance abortion. We want to put it in education for young girls in schools. So the priorities could be very, very different when we're even looking at the same area. So the way the money is channeled is problematic. We hope that in future possible that simulation modeling can be done, innovation from the ground. That's okay, and that's true. But again, we're still in the infancy, we're still in this, even to innovate, you have to know what you want to do. You can't innovate when you don't know what exactly you want to build. So you have to know the ideal before you can innovate and kind of use whatever is available, to create your own low-cost model. So we cannot run away from funding. And most of this also has to come from the Western world, because we have still not really fully developed ours, and that's when we're saying that we need more simulation modeling here. So the funding approaches and the way the money is channeled is a little bit of a problem, but that will take long, that will take engagement. And it's not true to say that nothing is changing. Of course, a lot of things are changing. There's a lot of emphasis to ensure that low-income country partners are on board, but there's, of course, it's a marathon. It's not a sprint, so it will take time before the best thing actually comes through. When we look at other things, for example, on the style of engagement as well, one of the presenters, I think it was probably the first or the second presenter, did present on the short visit medical missions, where colleagues from the Western world come for a very short time and then they go back. Again, yes, the attitude or the approach, what drives them to come and support work here is very noble, but it also has connotations or elements that we, the recipients, may feel uncomfortable with. For example, even in medical missions, it's wrong to think that you are, or the high-income country entities are coming to help us. That's not true. Any meaningful engagement or partnership is something, those that are lost. That's not true, and that approach should not be applied to surgical simulation, because we want a two-way beneficial engagement, and it's true when it's built like that. It's mutually respectful, it's mutually beneficial. We can look at other aspects again on the issue of, like you said, local content in the simulation. The simulation model should be built based on the need. I think my colleague from Brazil did present that it depends on the objective of why you're building the simulation model. And so if it depends on the objective, then the local learning objective is really, really important. And so if this simulation model is going to be built through a collaborative partnership between a high income and low income country, they need to develop and fully understand the curriculum, the learning goals, and the skills that are needed in every context or in every environment becomes much more important then, because then whatever you build then becomes more useful and easily acceptable on the ground. But if it's built with very little input and prioritization, even case content from the lower income country, then it becomes like one of those things that you can do in virtual reality, but you won't do nothing with in reality. And so it's useless for our patients, it's useless for our trainers, for our trainees. In terms of collaboration, again, the short medical missions are really short. And so sometimes they do more disruption than actually supporting. What we would like to see, as you know, we heard that the learning curve is quite steep in simulation modeling. It's important that the partnership or collaboration that is set up between high income and low income countries is a little bit medium term or long term. This so because it allows for capacity building as well on the ground. First of all, we learn with the right tools, and then we can see how we can innovate ourselves to build using local raw materials, and indeed even engaging partners locally, including industry, that could help us to build what can be cost-effective locally, but still work and serve us. So the relationship should not be short-term in simulation modeling. I suggest that it's better that any collaboration is a little bit medium-term or long-term, with a focus on also building local capacity so the locals can also learn and be able to do things on their own and not perpetually depend on the high-income partners to come and do most of the stuff. Even the research, like the professor said, you have to develop a prototype, you have to test it, you have to generate the evidence, even for ensuring that simulation modeling is well accepted in academic centers, in professional settings, in service. It's important that we try and prove that it's working. That can only be proved not by just word of mouth saying, I did it, it worked. No, it needs research. We have to document, we have to analyze, and then we have to present the information to whoever it is that we need to have buy-in that it's really working. That kind of research, of course, again, can also be done together with the collaboration. Ourselves in the lower income countries and the high income countries. But in global health, in the past, we've seen that even in research, we've seen injustice. We've seen colleagues that develop research protocols out there, and then they come here and say, oh, we have $1 million. Do you want to do this research? We don't know what you want to do. Just because you brought the money, you want us to do the research. We don't want that in simulation modeling and in global settings. We want to sit together on the table, decide together on what is really needed to be done, give our input, and then we do the research together. We are equal partners. Even when we share the outcomes of that research, we want to see an equal sharing of credit. We don't want far at the end, never the first or second author or the last author, but always somewhere in the middle. No, we want credit where it's due. We are equal partners. We want to see equal partnership. We may not have the resources to actually bring the simulation model to start with, but we have the playground. We have the patient. We have where you can do it. So it shouldn't be just because you bring the money, you want to take all the credit. No, it shouldn't be like that at all. So in a nutshell, I would like to say that simulation modeling is very, very important. I agree. It's a good way of moving forward to develop a human resource capacity for surgical services. And as you know, human resources for health is a key pillar of the health system. If we want good health outcomes, if we want stronger health systems, we need skilled and trained health workers that can actually do this work. Yes, it's true that many training sites have come up. We don't have enough teachers. We may not have enough resources. So simulation modeling is a key piece that can help us. We can even start now with COVID. We don't know how long COVID is going to take before it disappears, but we could start now. But we want equal partnership. We don't want neo-colonial mentalities in these engagements, because anything like that is toxic and it's going to just crumble and destroy everything we're trying to do. Thank you so much.
Thank you very much. I think you've raised very important points, and what you've said is very true. That simulation should also be based on need, so that it will be useful and acceptable in local people, and also local capacity building or local simulation models can be made. and also about the research. So we really appreciate the point very eBay. So would now like to switch to our student panelists. Could you kindly share with us your passion for making neurosurgery diagrams? And also, many studies have used medical students and trainees to study the efficacy and clinical transferability of surgical skills. So what roles could students and trainees play in helping to improve their surgical trainings? Chidiebere, you can continue.
Good evening, everyone. Hello, everyone. So, quickly, I'll be sharing my screen right now. My screen up. All right. Okay. All right. Hello, everyone. I'm Chidiebere, and I'm a medical illustrator. Sorry, I'm having some technical issues. Trying to share my screen. Okay. So I think my screen is up now. All right. So my passion for neurosurgery. Please, are you guys seeing my screen? Hello.
Hello. Yes. Yes, we can.
Are you seeing my screen, please?
Yes, we can see your screen. You can continue.
All right. Okay, so thank you for having me. I really want to appreciate InciSioN Nigeria, InciSioN Rwanda, and FAMSA. Thank you for having me. I'm Chidiebere, a medical illustrator, and I enjoy medical illustrator to be precise. So I did a first degree in chemistry from the University of Uyo, and I'm also the creative director at the Association of Future African Neurosurgeons and the Young Continental Association of Future of African Neurosurgical Societies. So my greatest aspiration is to be a pediatric neurosurgeon, redefining neurosurgery and bridging the language boundaries through my illustrations. It's quite an honor to be here. So my passion is in African is to passion is particularly to African patients, to represent them accurately, to break to circumvent language boundaries. You know, as a surgeon or a medical student, there is this boundary between a surgeon and the patient. You know, most times it's difficult to communicate with a patient with whose probably his language is not English. So as a surgeon or as a medical student, it's very, very important that we can use illustrations to communicate with our patients and to promote black skin illustrations and interest among African students. And you could agree with me that over the internet, if you are searching for illustrations per se on the internet, it is quite you won't easily see a black skin illustration over the internet, and that's my passion, is to promote black skin illustration on the internet, and of course make learning fun. So from the slides here, you would see I illustrated gliomas, and from the African setting, the concept is that an epic African setting, you would see this child drinking from a cup. So as when you study and you remember something like this during your study session, it will be quite easier to remember things like this. Now, students have a key role in improving surgical training. Number one, there could be their interest for the career. Their interest for the career. I would like to start with the interest. As a student, you know, there is this wrong perception about the concept of neurosurgery or surgery as a whole, that surgery is bulky, surgery is complex, surgery is difficult per se. But at the point where But if we must improve surgical training in Africa, there must be a point where students have interest for these courses. All right, and secondly, we also consider secondly, we also consider point where students' situation has improved. How many? Sorry, I'm having technical issue right now. So, how many illustrations? But of course, many have done it. So it's also possible that as a student, you can also do it. So find good mentors who are willing and able and always available to train you. Find good platform to be mentored. And from the illustrations you would see, we grow and we learn. So I still want to believe that from illustrations, from two medical illustrations, we can improve our surgical trainings in Africa. Thank you for having me, Chidiebere. Thank you so much. Thank you. All right. So I would love to take questions.
Webinar as fast as we can to prevent any further inconveniences. So I would like to welcome Dr. Mumba Chalwe to answer the next question, which was moving forward, what areas are still left to explore in improving surgical training through simulation in Africa? And refer to a dissociative simulation model across medical faculties and a need for interdisciplinary partnerships, surgeon, anesthetics for improved non-technical skills. Sorry about that. You can still help us identify relevant non-medical partners and collaborating with the same, how does the multidisciplinary software engineers, material experts, designers, policymakers, core administrative faculty, etc., followed critically by mapping of assets. When we talk about assets, we mean surgical simulation models. You can also refer to the ongoing Global Surgical Training Challenge to drive innovation in surgical simulation training for low resource settings. Thank you very much. You're welcome.
Now, am I audible? Okay, thanks for having me, and I just wanted to really encourage the previous speaker, Dr. Chidi, for pushing through. Thanks for the question. So I believe that the future of simulation training, where can we go? Based on everything we've discussed, we know where we should be. We know what the ideal is. I would say it would be worthwhile to actually look into being even more innovative in terms of looking at using things like virtual reality, augmented reality. And I think before I go any further, it's important to emphasize that these don't need to be the costly, expensive things that we may be imagining. We need to be, as Africans on the continent, awake to the fact that we have what we need right here on the continent. As part of the discussion, Mr. Arsen did say, how do we collaborate with software engineers, with educators, with IT specialists? And I think that's a very important point to touch on, because we cannot go further without looking at our colleagues and our partners who are in the other fields. In medicine, we like to call it the MDT teams, in managing complex cases, you know, with difficult patients. And I think that concept can be extrapolated into surgical simulation training. We've already seen it in developing of tools like the WHO checklist. It was actually adopted from the aviation checklists. So already you can see that we are borrowing from other industries as it is. So why not just go the whole mile? You know, walk the whole 9 yards and involve our colleagues in the different sectors so that we end up with a very powerful tool that we can use right here, a homegrown tool that we can use right here on the continent. So if you ask me where I see the future of surgical simulation, that's what I envision. Of course, we do have challenges, but it's important to look to the future, of course, and envision where we could be. There is currently a global initiative, the Global Surgical Challenge, that is ongoing with several partners from around the world. And I'm privileged to be part of that team. And what we're doing right now is bringing together teams from across different parts of the world to come up with innovations that can then be used in surgical training. So I think we do have a very bright future ahead of us, and it's important to change our attitude. I know as African surgeons on the continent, African health practitioners on the continent, we tend to have a very fatalistic approach. By that I mean, we have a very, not negative, but fatalistic, where you believe this won't work, we have this challenge, you know, we have problems with electricity, we have problems with the basics, how can we be thinking of virtual reality? And to that I say, we need to get out of that fatalistic mindset. Get out of that fatalistic mindset and just see ourselves as valuable players on this, on the map. Once we come out of that, I believe that's a first step. And I'll be honest, the first time I you know, got involved with the Global Surgical Challenge, I thought to myself, what's an African surgeon doing on panels like this? I really was not, you know, I was not moved to want to be part of this, because I thought, well, the fatalistic approach, what can we possibly do? We barely have power. How can we be thinking of virtual reality and augmented reality? But that's not the case. We have so much that we can do right here on the continent. There's so much that we can do with the resources we have. One of the presenters alluded to that fact. So it's very important that we start to think in that future, because the future is now. There is no, you know, far flung future that we can look forward to. So I'm very optimistic in terms of what we can do for surgical training on the continent. I am very, very optimistic. And I believe that if we can, you know, look at a webinar like this, if we can all come together with unified purpose. I'm starting to sound like I'm at a rally now, but you know, if we come together with a unified purpose of pushing this agenda, I believe there's really nothing we can't achieve. There was one point I just wanted to make. It's a bit off topic from my point of discussion, but Prof. Makasa mentioned something about these missionary visits, surgical missions, and I actually had a good experience with a certain organization who actually, they're urologists, and they go around the world and they have a mid to long-term relationship. Throughout my residency, I actually underwent these surgical missions as they were with them for more than 4 or 5 years. And I've seen in my current practice that the surgical skills that were transferred then are still very much applicable. So it's important, even as we're going down the path of improving surgical training through simulation, to really adopt strategies that are suitable for our context. You know, in our context, I don't think there's much benefit in training on, Da Vinci robot simulators, when in our setting, we're more laparoscopic surgeons. Our conditions are not necessarily suited to that kind of training. So I believe we have some work to do, but we've come a long way. And we need to take up the opportunities that present themselves. I would encourage everyone who's listening to actually look up the Global Surgical Innovation Challenge and have a look and see how you can participate. And we need to put our best foot forward. We cannot have a situation where a call for innovators has been made and there's so few Africans there, simply because, our attitudes don't, we don't believe in our capabilities, and we look at things as too futuristic. We need to take the bull by the horns and just go for it. And I'm sure we can. I really believe we can really progress in terms of moving forward this agenda. So I believe the future is bright and the future is today. Thanks for having me. And I can see some comments in the chat. Back to you, Mr. Arsen.
That's a great and very, very detailed insight about surgical simulation and the correlations and the innovation that comes around it. We really appreciate speakers and being patient with everything that has been going on throughout the webinar. Now it's our time to go to the question and answer session. So I'd like to welcome my colleagues to continue with that part. Thank you very much.
Thank you so much, Arsen, and all the speakers. So we are now to the question and answer session. This is Tony Kiprono from FAMSA, and most of the questions have been raised in the chat box. And thanks to the panel, they have been engaging with our audience in terms of replying to their questions. And so the question that asked was, what method to keep trainees interested in simulation? That was already answered with by Prof. Patel. We also had the second one, how do we incorporate the time limit encountered during medical training and surgical simulation? It was also answered. There's another one where I think it hasn't been answered yet. Is there a part of training in medical illustrations in Africa? And do you think that an African Association for Surgical Simulation would help? So this one I directed to any of the speakers would want to comment about it. Yeah, so far that is the question I have gotten. Yeah, thank you.
Hello, everyone. I would love to answer a question of, is there a part of training in medical illustration in Africa? Particularly, so there is no particular institution, let's say, that's responsible for training students in medical illustration. So it's just having a good mentor who is able to guide you through the illustrations and being and using your own personal skills to project yourself. So there is so the only part of training medical illustration in Africa is just seeking for mentors who are already in the field to guide you through. But per se, let's say if there's an undergraduate degree for medical illustration, I'm sure there is none in Africa. So it's just your personal push or your personal personal strive to become a medical illustrator in Africa.
So thank you. I also like to briefly speak to the issue of partnership across Africa that has been mentioned by a number of panelists, and the issue of collaboration is key to so much of what we can achieve together. Of course, we all know if you go alone, you go quite fast, but if we go together, we'll go quite far. So I think the beginning of collaboration is what we're doing here today, to have contacts of one another and to continue to share ideas. You have an innovation you think can benefit somebody in another country on the same continent. A simple email, reaching out to one another. You have a research on simulation, for instance, like we've spoken about today, and you think that you can also do this multinationally, not only multi-center in your own country, but you can also introduce that research idea to another colleague in a neighboring country or across the continent. So I think collaboration, not only in terms of training, but also in research, is the way to go. Thank you.
We had the most excellent and engaging speakers that anyone can wish for. So we are very, very, very appreciative, and we hope that the information and the education that we got from this webinar is going to shape us, change our mindsets, also increase our perception about partnerships, interdisciplinary collaborations, and also for the purpose of reaching to a better African surgical simulation training in undergraduate degree and trainees. So I would like to add that this video was being recorded, and the video and the audio recording will be given in the coming hours to the speakers. Will be given, the link will be provided through their emails, and the rest they can check our Twitter accounts for InciSioN Nigeria, the Global Surgery Rwanda, or InciSioN Rwanda, and on FAMSA official. So we really appreciate everything you've done for us through this journey. We thank the chairs of InciSioN. Katayun, thank you for being with us, and I thank my fellow teammates that have been able to pull this off. It was a very, very interesting journey, and we hope that more of these conversations are going to keep on going, because it's better said than there said. And I hope that the future of the African surgery, our low middle income countries are going to develop, and surgery, as it has been very, very neglected. It's a very, very good thing to see that most people are stepping up to talk about the issues, and InciSioN has been really helpful. We thank FAMSA for the Federation of African Medical Student Association that has organized and brought the African Medical Students Associations in general on this webinar. And furthermore, we wish everyone a safe and happy weekend. And yeah, those are my closing remarks. I don't know much to say. So thank you, and thank you. I think we are at the end of the webinar, unless Nelson is available to say something and thank some of the people. Thank you.